Okay, in our last group we finished up with SVT, and now we're going to be moving on to ventricular dysrhythmias. There are, as I mentioned before, a couple of things I threw in that are ectopies that are common that I won't necessarily test you on, but they're common, so I want you to be familiar with them. And earlier we had talked about premature atrial contractions, or PACs. Patients can also have what are called premature ventricular contractions, or PVCs. Now, PVCs, now remember PACs were an ectopic beat that originated in the atria, and so it followed pretty much the same pathway that it would have otherwise. It just kind of superseded the SA node, and so you had this early looking beat, but it kind of looked like the rest of the rhythm, except it was early. PVCs, though, this is an irritable area that's in the ventricle. So this is, once again, not a rhythm, it's an ectopy, but this is an irritable area in the ventricle. And this irritable foci will fire off an electrical impulse before the SA node can, and it'll kind of take over. And so when you're looking at this strip, you notice a couple things that kind of stand out, and that's these big old things right here. So that's going to be our PVCs, and I'm going to explain those. We'll come back to them. But remember, this is ectopy, and so we're going to ignore them for now, and we're going to look at the underlying rhythm, because we got to figure out the underlying rhythm. PVCs are not a rhythm. So ignoring the PVCs, they're not there. Is the underlying rhythm regular or irregular? And so if I take my pencil or whatever, and I mark beat to beat here, the underlying rhythm is regular. Now the PVCs come in a little earlier, but the underlying rhythm is nice and regular. Rate, let's see, we got 6 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Rates at 100, and you'll notice I counted the PVCs. The monitor is going to count that, so we'll count those. So the rate is around 100, so we're a little on the tacky side. And on the underlying rhythm, I'm going to look for P waves. And so you'll notice on this particular rhythm, I have P waves, and I do have a P wave in front of every QRS. This one got a little squishy, but there's a P wave in front of every QRS. We don't see a P wave in front of the PVC. And they're consistent. They look about the same. Remember, I'm going to do a PR interval, and so I'm going to measure from the beginning of the P wave to the beginning of the QRS. And so beginning of the P wave to the beginning of this QRS is 3 baby boxes, maybe a little more. And so my PR interval is about a 0.12 to 0.14. So far, it's regular. The rate's about 100, so it's tacky. I have P waves, a P wave in front of your QRS, and a normal PR interval. The underlying rhythm is sinus rhythm, okay? I would go ahead and measure my QRS, and the QRSs look like they're about 2 baby boxes, so 0.08. I would check out my ST segment, and my ST segment, okay, remember that's the space between the QRS and the T wave, and that is isoelectric, okay? It's flat and isoelectric. T wave is a little bump, it's upright and rounded, and they look pretty consistent all the way through. And so these are a little more upright than those are. I'll just measure these then. And so I'm going to do my QT interval. And so from the beginning of the QRS to the end of the T wave, you'll notice I've got a big box that's 0.2, and I've got 4 baby boxes after that. So my QT interval is 0.36, okay? All right, so that's my underlying rhythm. I go back to these big old things here. So PVCs, irritable area in the ventricle, and because it's going to fire and that impulse is going to go in kind of this retrograde backwards sort of, configuration, it's wide and bizarre because it's going to take time for that electrical impulse to travel back up through the ventricle. And so this piece of it right here is actually your QRS, okay, and it comes down to here. And the QRS will be wide and bizarre, so it's certainly bizarre looking. And for wide, you'll see that it's greater than 0.3 and then 3 baby boxes. So it's greater than 0.12 seconds. And because we're actually going to measure it, it starts here and it looks like it ends probably somewhere around here. And so that's why I'm saying it's at least 3 baby boxes, almost 4 baby boxes. So it's somewhere between 0.12 and 0.16 seconds. My T wave, this right here is my T wave. And you'll notice that it's kind of really tinty and is of opposite polarity. Now remember, the T wave is representing ventricular repolarization. Well, this was an early beat in a cranky ventricle, and so repolarization is also looking kind of cranky too, okay? All right, so I have sinus rhythm with PVCs, and what kind of setting? When am I going to see this? Well, it's also a very common dysrhythmia that can happen in healthy and diseased hearts. Once again, I'm betting at some point or another, you guys have all had PVCs somewhere along the way too. But we could see it in problems too, because we can see this in patients that have had heart attacks, or they're hypoxic, or they have heart failure, or damage to the myocardium. You'll notice digitoxicity pops up again, electrolyte disturbances pop up again, stress, caffeine, nicotine, alcohol, cocaine, methamphetamine, all sorts of things. So basically, do a patient assessment. If the patient is stable, then just try to figure out what might be the cause and fix that. What we do look at patterns of PVCs. Now, right now, you do have 2 PVCs that look about the same, and so when we see morphology that looks about the same, then we call those uniform or unifocal, meaning that we think that it comes from one specific irritable area. Now, if you had another PVC along the way that looked totally different, didn't have this same morphology, maybe it kind of went beep beep or whatever, then you have multiform or multifocal PVCs, and we think that that means it comes out of 2 different or more than one irritable area, and that might be a more ominous sort of thing. Sometimes, PVCs have patterns, and so we may have PVCs every other beat. So you've got a PVC, you've got a normal beat, you've got a PVC, that would be called bigeminy. If this pattern were to continue, where we have a PVC, we have 2 normal beats and a PVC, that's trigeminy. But that would need to continue, because I would have to have normal beat, PVC. So sometimes we'll look at patterns. 2 PVCs in a row that look the same are called a pair. 2 PVCs in a row, PVC, that are different are called a couplet, and that we're worried about irritation. The other thing we look at with PVCs is, remember the back of the T wave. Now, this is nowhere near the T wave, and that's good, but if this PVC landed on the back part of my T wave here, that's called R on T, and remember, the back of the T wave is a sensitive time in the cardiac cycle. The heart can respond, but abnormally, and your patient could go into a lethal dysrhythmia. So, intervention, assess your patient and fix the cause, whatever's making the heart cranky, and the PVCs will go away. Now, VTAC, when you're looking at VTAC, one of the things you may notice right off the top is that this VTAC looks like PVCs, just a bunch of them. So let's back the trolley up here. Whoops, went the wrong way. So big wide QRS, T wave of opposite polarity. What if I had a string of these in a row? Whoops, went the wrong way again. That would be VTAC. So this is my QRS, that's big and wide. This is my T wave of opposite polarity. Big wide QRS, T wave of opposite polarity. So technically speaking, we're looking at, a little run. If we had just a little, technically speaking, a bunch of PVCs in a row is VTAC. So rhythm, is the rhythm regular or irregular? When we march it out, it's nice and regular. Rate on this, so here to here, 6 seconds. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 14 to 15. So I'm 140 to 150 beats a minute, and that's typical. VTAC is typically greater than 100 beats a minute. P wave, there is none. This is a foci that comes from the ventricle, and so we don't have a P wave. Sometimes the SA node will attempt to be firing off too, and we may see a P wave weirdly kind of in the bottom of the T wave, or maybe smashed up against a big wide complex, but no P wave. So ratio, we don't have a P wave. QRS complex is wide and bizarre. And with VTAC, like the PVCs, the QRS needs to be 0.12 or greater. And then we've got the wonky T wave that is of opposite polarity, and usually like this, kind of tall and tenty. You can't really measure, we don't measure a QT interval on VTAC. So what do we do with this? Setting is same as PVCs, you get kind of a cranky heart. What do we do? Assess your patient. The patient in VTAC could be okay, unstable, or dead. Now, if they're okay, then we're gonna, okay meaning that we've done an assessment. They're alert and oriented, they're warm and dry, blood pressure is within normal limits, their skin color, temperature, is good, their capillary refill looks fine. In that case, when they're stable, we'll get a 12-lead EKG because we're only looking at one view, so maybe in another view this doesn't look the same. We'll get a 12-lead EKG. We'll consider antidysrhythmics, and the 3 antidysrhythmics that American Heart recommends for stable VTAC are procainamide, amiodarone, and sotalol. If they're unstable, so they still have a pulse, they're unstable, so they're hypotensive, they're having chest pain, they're showing signs and symptoms of heart failure, signs and symptoms of shock, they're having, change in level of consciousness, then synchronized cardioversion. And so we would go ahead and get that going as soon as possible. If they're dead, Annie, are you okay? Annie's not responsive. Remember, call for help and start chest compressions. Now, this is one of our 2 shockable rhythms. Pulseless VTAC and VFib are shockable. And so you've got to start the compressions, but we need to shock as soon as we can. So as soon as we can get that monitor defibrillator rolled into the room and get them attached, then we're going to go ahead and charge, and we're going to defibrillate. And then immediately after we defibrillate, we're going to resume CPR. And so you guys we went through the ACLS. Let me start with BLS, ACLS algorithm. And hopefully we can get them back into some sort of a sustainable rhythm. So that's our plan with VTAC. Now, torsades de pointe, we'll talk about this when we get back together to do a little bit more with ACLS. Torsades de pointe is also called polymorphic ventricular tachycardia. Now, I'm going to back up a little bit. So, technically speaking, this VTAC is monomorphic, meaning all of the complexes are the same. So, this is our monomorphic VTAC. This, our torsades, our torsades is polymorphic VTAC, meaning that the complexes change. And torsades de pointe means twisting of the points. And so what you notice is this almost seems like it's kind of wrapped around a helix sort of thing. So it has a different appearance, and it's a different mechanism going on in the ventricle. Torsades is a little different than just a monomorphic VTAC. So rhythm, regular, irregular. If you look at rhythm from beat to beat, it's regular. I know it seems weird because it looks so strange, but it's regular beat to beat. Rate, do I have rate on here? 1, 2, 3, 4, 5, 6, a little hard to count. 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. Well, it's pretty darn fast. We're well over 200. And torsades is a little bit hard to count. So our rate is quite rapid. No P waves, no PR interval. Wide bizarre QRS that is polymorphic. It changes shape as it kind of twists around. So we don't really have a ratio ST segment. T wave is the bizarre. We're looking at this. This is most likely the QRS and the T wave. QRS and T wave, but you'll notice that it twists, so we really have a hard time. We can't really identify that either. So setting. Most often patients go into torsades because of a prolonged QT interval. Remember, the back of the QT interval is a very delicate part of the cardiac cycle, and if it's prolonged, if the QT is prolonged, it's more likely that an impulse is going to jump on there and create this on the monitor. There's a lot of antidysrhythmics, and we'll be talking about them, that actually prolong QT interval. So some of the ones we just mentioned, procainamide, sotalol, amiodarone, and quinidine, all prolong QT intervals. So that's one of the things we have to monitor because it puts the patients at risk of torsades. And then, like I said earlier, there are some over-the-counter antihistamines, cold medication, and then some prescribed antibiotics and tricyclic antidepressants that can prolong QT interval and put them at risk. So you see this on the monitor. Annie, are you okay? You've got to assess your patient. If they are still conscious, we want to, we're going to consider magnesium. Typically speaking, when you see this, your patient is dead, your patient is dead. And so we're just going to go ahead. Annie, are you okay? They're not responsive. Call for help. We'll go ahead and start CPR. We will shock this, so you can defibrillate this. So as soon as you can get the monitor in and get it attached, we're going to go ahead and shock. You're going to use energy just like you would if it was a monomorphic VTAC. The only addition to torsades is magnesium. And we're going to try to get a gram or two of magnesium in, and we can mix it in like 10, maybe 25 of saline. And if a code is going on while you're doing this, don't stop the code for this. Just go ahead and find a port, and we're going to get that in over 5 to 10 minutes or so. The magnesium in a patient with torsades acts as an antidysrhythmic in that it makes it a little bit easier to defibrillate and get results, get good results, get a sinus rhythm. So that would be our addition. We don't like to see this. VFib, well, we really don't like to see this. So you see this on the monitor, you still have to check your patient. Annie, are you okay? If they open their eyes and say, what's up with you? Well, they're not in VFib. There's chances are good there's a lead off. So Annie, are you okay? And Annie's not responsive, then you're going to go ahead and start your chest compressions. And we're going to get the card into the room. So VFib is also shockable. So pulsus VTAC and VFib are our only two shockable rhythms. When you're looking at this, you'll notice that the rhythm is irregular. It's very irregular and chaotic. And this is kind of a medium VFib. Sometimes we talk about a coarse VFib where you see a lot of undulations and chaotic stuff, to a fine VFib where it's kind of so quiet it almost looks like asystole. So rhythm is very irregular. You can't do a rate. I mean, there's nothing here. You don't see QRSs or P waves or anything else. This is just the fibrillations of the ventricle. So no rate, no P wave, no PR interval, no QRS complex, no ST segment, no T wave. So what kinds of things cause this? Well, bad things. So this can heart attack. When patients die of having a heart attack, it's typically that they've gone into VFib. We can see this with cardiomyopathy, coronary artery disease, hypoxia, myocarditis, electrolyte issues, drugs such as cocaine, methamphetamine, an electrocution accident, things like that can create this. So as I said, you've got to assess your patient first. And, pulsus non-responsive, you're going to initiate CPR, and we're going to get our code team into the room, and we're going to defibrillate as quickly as possible, and we're going to be moving right into the ACLS algorithm. Asystole, well, this was pretty easy, huh? There's not much going on here. So asystole is also sometimes called ventricular standstill. Basically, there's no electrical activity going on in the heart. Sometimes the P wave will, or the SA node will still be firing, but it's not capturing anything. So sometimes instead of just seeing a straight line, you'll see a line and some P waves, but no QRSs, T waves, or anything else. That's a P wave asystole. It's still dead. So you still, when you see this on the monitor, you always have to assess your patient. Annie, are you okay? It's possible that the lead has come off. If they're truly in asystole, they won't be okay. They'll be dead because they have no cardiac output. So once again, no rhythm, no rate, typically no P waves, no PR interval, no QRS complex, T waves, none of that. Asystole is bad news. It is dead, and that's always bad news. But the thing with asystole is because we really don't have an electrical activity going on here, we can't defibrillate. Defibrillate is trying to reorganize electrical activity, and we have none. Really all we've got is good airway breathing, chest compressions, and remember from ACLS, we especially want to think about H's and T's. We want to figure out what the cause is and try to fix that. So that's what we're going to go at. Good CPR, good airway breathing, figure out what the cause is, and hopefully we can get that patient back. You may see with asystole, it is recommended that if we see this on the monitor, we check in a different lead also, because it's possible that the patient is in just a very fine VFib and not asystole. And if they're in VFib, we know that we can shock them and we have some other options for them. But this is bad news. All right, the heart blocks. Now, remember, in terms of testing, I won't test you on first-degree AV block. This is fairly common, and, so you're likely to see it. If you're looking at your packet, you'll notice that the heart block is just a description for dysrhythmias where there's a delay or problem with conduction from the AV node to the ventricle. And so we have three types of heart blocks. There's a first degree, which is what we're looking at right now. There are two second-degree AV blocks. There's a second-degree type 1 that's also called Mobitz 1 or Wenckebach, and then there's a second-degree type 2 that's also called Mobitz 2. And then there's a third-degree heart block, and that's also called a complete heart block. So what we're looking at is a first-degree heart block. And so with the first degree, everything is basically a sinus rhythm with a lengthened PR interval. Something has going on in the AV node, and so the AV node is hanging on to the impulse a little longer than it should. So let's take a look at this. So is the rhythm regular or irregular? And if we check from our R wave to R wave, the rhythm is nice and regular. We're going to look at the rate, and so I've got 6 seconds from here to here. 1, 2, 3, 4, 5, 6, 7, 8. The rate on this is in the 80s. Now I'm looking for my P waves. And so this is my P wave here, P wave, and you can see how far away the P waves are from the QRS. Okay, so I've got P waves, and I do have a P wave in front of every QRS, but when I go to measure the PR interval, I see that it's quite long. Let me see if I can find something I can line up on. Boy, not much of anything. Okay, so my PR interval starts here. So I've got 2 baby boxes to here, and then I've got, so that would be 0.08, and here's 0.0 or 20. So I'm at 0.28 and 1 more baby box. So my PR interval is 0.32. That's pretty long. Remember, the PR interval shouldn't be any longer than 0.20. I still have QRS, and so I can still measure my QRS. My QRSs look about the same, or they look the same all the way through. I'm going to measure my QRS from the beginning. So the beginning of my QRS is right here to the end, and it appears to be about 2 baby boxes, so that looks fine. ST segment. When I draw my isoelectric line, my ST segment seems to be isoelectric, maybe like half a box below baseline. It's hard to tell. Sorry. So ST segment looks pretty good. T wave is upright and rounded, and then I would do a QT interval. And so I'm going to measure from the beginning of the QRS to the end of the T wave on that. So when we look, like I said, a first degree AV block is fairly common. It really doesn't mean that there's, that the conduction system is falling apart. So when can we see this? Ischemia or injury, an increase in parasympathetic stimulation, Medications, so DIG, amiodarone, beta blockers, calcium channel blockers are medications that can cause first-degree AV blocks, and sometimes we just don't really know. So most of the time, unless the patients get really bradycardic, they're stable. So we'll just continue to monitor them. We'll look at their medications and try to see if there's something we can adjust, and this isn't something we get too excited about. So second-degree block, now remember there's two second-degree blocks. There is the second-degree block type 1, and this is also called Winky-Bach or Mobitz type 1. So there's second-degree type 1 and there's a second-degree type 2 that we're going to look at in just a second. Now, one of your cues, one of your clues for heart blocks is this. First-degree heart block and complete heart block will be regular. Second-degree heart blocks are going to be irregular. And when we look at this strip, you'll notice it looks pretty good, but then I got this right in the middle here, and so this strip is irregular, okay? So irregular, all right? Now I'm looking at rate, and so I've got 6 seconds from here to here, and I'm counting 1, 2, 3, 4, 5, 6. My rate's in the 60s. Now I'm looking for my P waves. And so I got a P wave here, and I have a P wave here, and I have a P wave here. Now you may already be seeing something going on with the PR intervals. And then I have a P wave here that is not followed by a QRS. This is my block. I have a blocked P wave. And then, so P wave with no QRS, and then I've got P wave, P wave, P wave. And so I've got this extra P wave hanging out by itself. So that's the other clue that it's either a second or a third degree heart block. So remember that first degree heart blocks and third degree heart blocks are regular. Second degree heart blocks are irregular. First degree heart blocks have a P wave for every QRS. Second and third degree heart blocks have more P waves than QRSs. So this one has an extra P wave. So I have more P waves than QRSs. Now when I start looking at PR intervals, I notice something. So my PR interval on this first one looks like it's about a 0.20. But PR intervals should be consistent. And when I check this one, my PR interval is longer. PR interval on this one is about a 0.28. PR interval on this one is longer still, because the PR interval on this is about a 0.40, maybe a little longer. So I went from a 0.20 to 0.28 to 0.40, and then I have my blocked P, and then look what happens. I reset. I have that same pattern, 0.20, 0.28, about a 0.4, and then what do you suppose is going to happen on the other side here? I'm going to have my blocked P, and then I'm going to reset. So there's a little poem that goes, longer drop, then you have a Winky-Bach. So Winky-Bach is my second degree type 1, Winky-Bach or Mobitz 1, it's all the same one. So what do I have? I have a progressive lengthening of my PR interval, a drop, and then a reset with progressive lengthening, and that's second degree type 1, is that pattern there. Compare that to second degree type 2. Now second degree type 2 is a little more ominous. Second degree type 1 isn't really a problem with the conduction system, but second degree type 2 can be a problem in that it can become a complete heart block, and so I get a little more worried about this one. So second degree type 2, what do I see? It's irregular. And remember, because it's irregular and it's a block, because I see the extra P waves, I know it has to be a second degree. Second degree type 1, we've already said, has progressive lengthening and then that drop or block. And I know that I have more P waves than QRSs, and that means it's got to be either a second or third degree. But I know it's a second degree because it's irregular. Okay, so rhythm is irregular. I look at the rate, and I've got 1, 2, 3, 4. Rate's pretty slow. Rate's only in the 40s. I look for P waves, and I have a P wave, a P wave, a blocked P wave, there's no QRS, another blocked P wave with no QRS, a P wave, a P wave. So I have more P waves than QRS. Now I'm going to look at the PR interval. And what you see here, so my PR interval here is about a 0.18. But what you notice is every time there's a P wave in front of a QRS, I have the same PR interval, 0.18. Now these are blocked, but here's a P wave in front of a QRS with a 0.18, maybe it's, about 0.18 to 0.20. Same thing, about a 0.18. So what's consistent here, rather than having a progressive lengthening, I have more P waves than QRSs, but every single time there's a P wave in front of a QRS, the PR interval is consistent, okay? That's what makes this a second degree type 2. You'll notice there's something else that's kind of ominous about this, in that I have a widened QRS, and so this is a problem that's lower down in the conduction system. So like I say, this second degree is more ominous than the slide that we looked at previously. See how this has a narrowed QRS? Okay. This could turn into a complete heart block. So what am I going to do with this? You know, setting on second degree type 2, Mobitz 2, heart attacks, like I said, degeneration in the conduction system, which is why I'm alarmed about it. And we also see this with acute myocarditis, which is also alarming in this. So assess your patient. You know, once again, you know, we want to do a good assessment, maintain airway breathing circulation. If the ventricular rate is within normal limits, they may be stable. And, you know, this has a heart rate of 40, and so that in and of itself is problematic, and this patient probably isn't all that stable. They're probably hypotensive. They may be having some chest discomfort. Now, if they're stable, we got a little time to figure out what's going on. If they're unstable, then, you know, well, regardless, if they're unstable, we're going to follow ACLS protocol. And so the first thing would be to administer atropine. Patient probably won't respond to the atropine. They may or may not. What you may see is just the, you know, we may see more P waves, and that's about it. We may have to go, the next step will be transcutaneous pacing if the patient is unstable, but really, really watch, because they may go into a complete heart block, which is this, our third degree heart block. So this is not good news. We're going to look at this. We notice that it's very slow. And so we look at the rate, you know, irregular. We determine that by looking at our QRSs, and yes, it's regular. Rate is only 30 here, and we go looking for P waves. And you'll notice something. I've got P wave, P wave, P wave. I have a T wave that looks kind of funky. I'm wondering, because I've got P waves spaced out, so I'm wondering if I make a little ruler, make yourselves a paper ruler and put a mark here and a mark here. I know these are P waves. And then move that ruler down so that your first mark is here. Your second mark is probably going to be right here. Yes, there's likely a P wave on top of this T wave. And then move your ruler down so you leave your mark, first mark here, your second mark will be here, and move it down so your P waves are consistent. Yeah, there's a P wave on top of this T wave here with the T wave, P wave, P wave, P wave, and probably once again a P wave up here. So complete heart block in that the SA node is continuing to fire at a regular interval. And if I count the P waves, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, my SA node is firing off at about 120 beats a minute. It's not getting to the ventricles. And so the Purkinje fibers have to kick in. And remember, the Purkinje fibers are ordinarily pretty slow, somewhere around 20 to 40 beats a minute. And that's what you see, 30 beats a minute here. So complete and total disconnect between the atria and ventricle. What do you suppose cardiac output is like? I mean, I got plenty of diastolic filling time, but you'll notice the atria are contracting away. You know, sometimes even when the the ventricle is trying to repolarize and things like that. So my cardiac output isn't likely to be very good. All right, so setting. Heart attacks, digitoxicity, could be chronic degenerative stages that occur, usually related to elderly patients, could be coronary artery disease. So once again, assess your patient. Maintain airway, breathing, circulation. If they're stable, you're certainly going to continue to monitor them very carefully and contact the healthcare provider immediately. We want to make sure that we've got a TCP available. If they're unstable, then we're going to go ahead and, technically speaking, the ACLS protocol is to give atropine. Atropine is only going to increase the rate of the P waves. It's probably not going to help with your QRSs. So get the pacer in the room, TCP, because we need to pace this patient and get them going a little bit faster. We need to figure out what the problem is. If it's a heart attack, then the patient needs to go to cath lab, and we're going to try to reperfuse. If it's a degeneration of the conduction system, they're going to require a permanent pacemaker in order to have decent cardiac output. So this is kind of scary. I do want to go back because I realized that when I talked about the Winky-Bach, the second degree type 1, I really didn't talk about settings. I had said that it's a fairly benign thing, but I really didn't get into the settings piece of it, so back up a little bit. Medications can cause this, potassium issues, heart attack, and increase in parasympathetic stimulation. So assess your patient and go from there. If they're bradycardic and symptomatic, that will go into the bradycardia algorithm for ACLS. But monitor your patient, call the healthcare provider, and like I say, for the most part, this is kind of a temporary thing. Okay, moving past, this is the last thing we got to look at, and this is our paced rhythms. Now, when you get into, or in class or the recording, when we talk about pacemakers, I'll be talking about the pacemaker generator and patient teaching and all that other stuff. But if you've got a patient that's got a pacemaker and you put them on the monitor, the paced rhythms are going to look a little weird. So the pacemaker has a generator sensor that's typically a tiny little thing that's implanted in a subcutaneous pocket, under the skin, beneath the clavicle, and then there's a wire or wires that are dropped down into the right side of the heart. And those wires are monitoring to see what's going on with the intrinsic rhythm, and then we'll send an electrical impulse, depending on how the pacemaker is programmed, and the doc will program that. So what you see, we're going to look at both of these, because what I have examples are of, what these examples are is, this is what's called ventricular pacing, and this is atrioventricular pacing. So go back up to the V pacing, the ventricular pacing. What you notice about this is these lines here, and these lines that you see are what are called pacer spikes. And so with this patient, I actually can see what looks like some P waves below that. Can't really tell what's going on. It's hard to see. For some reason or another, though, whatever the underlying rhythm was, it wasn't capturing myocardium, and so that's why this patient got a pacer placed. And so this is V-paced. The pacer is set at a specific rate, and rate on this, what do we have? 1, 2, 3, 4, 5, 6, 7. Rate is about 70. So pacemaker's probably set about 70 beats a minute. And the intrinsic rhythm has to be slower than what the pacer is doing because it's 100% paced. And so the pacemaker is continuously sensing, and if there's not anything coming from the heart, it'll send out a little electrical impulse. That's our pacer spike. And then what you're going to see behind that is a big wide QRS, okay, followed by my T wave. And that's called capture, ventricular capture. Now, what I have to do then, if I see this on the monitor, is check the patient and make sure they actually have a pulse of 70. Because remember, this is just electrical. So I should have pacer spikes. I've got pacer spikes. I've got capture behind it. And I would check to make sure I have a pulse of 70, and I would check the blood pressure, skin color, temperature, capillary refill, and things like that. Now, we would call this 100% V-paced, meaning that every single one of these beats is V-paced. There are no intrinsic beats. Now, when you look down below, this is what's called AV pacing, or atrial and ventricular pacing. How do I know? I see two pacer spikes. And so this first spike is to stimulate the atria, so I get a little atrial contraction. And don't worry that you don't really see anything here, because remember the atria is teeny tiny. Now the pacer is programmed, and this one says 61, so the pacer is probably set at 60. The pacer is programmed so that it's monitoring both atria and ventricle. If there's no stimulus from the atria, intrinsic stimulus, it'll stimulate the atria, and that's what we see. And then it waits for a prescribed program length of time, and it's usually the equivalent of having a PR interval of 0.20, so it's 20 milliseconds. And if there's no stimulus to the ventricle, then it'll stimulate the ventricle, and then we see our ventricular, this is our wide QRS, and our T wave, our ventricular capture. Now, one thing you notice about this strip, there's something interesting that happens at the end of the strip. And before I point it out, go look at that last complex and see what you see. See what you think. What do you see? Hopefully you picked up on the fact that I went from having atrial and ventricular pacing to just V-paced. Why am I only V-paced? See this? What do I have right here? A P wave. So remember, the pacer is consistently sensing what's going on in the heart. And for some reason or another, the SA node kicked out an electrical impulse, and I got a P wave. Now, so the pacer inhibits, and it doesn't send out a pacer spike for the atria. It didn't need to. But it watches, and it'll watch for that prescribed length of time. And because the impulse didn't travel to the ventricle, it's going to go ahead and pace the ventricle. And so that's why here we only have ventricular pacing, because we didn't need atrial pacing. Okay, so when you're looking at those paced rhythms, you want to know what the pacer is set at. If the pacer was set, for example, at 60, the rate should never be less than 60. So we want to look at that, and we want to look to see how much of, do we have intrinsic rhythm, how much is actually being paced, do we have pacer spikes followed by capture. You never want to see pacer spikes hanging out there by themselves, and you always have to check the patient. So that is the end of our EKG. There'll be some practice strips for you to try out on your own, and certainly you'll get a chance to ask me any questions when I see you in class or we meet on discussion boards. So that's all for now. Thanks so much.